last talk was fun. I was almost giddy. This talk's not as fun, but as I said, when you come to a meeting, you want to get stuff, and I pray that some of these situations I'm going to show you, you are never, ever in, and most likely you won't be in. But as long as I've been in this career, it still astounds me when I'm in a situation, well, that's the first time I've ever seen that, and why didn't everybody ever tell me that? So some of the stuff you're going to hear is not in textbooks. It comes from experience for somebody who's been on the front line. I want to define the fatal ECMO scenarios, and all these scenarios not necessarily were caused by ECMO, but they involved ECMO. They include scenarios where ECMO initiation was an improper modality. It was chosen for support and it shouldn't have been chosen. There's some rare scenarios in here presented to the audience so that you may not have the same difficulty that I had, or you may be able to avert a scenario in that situation. Many of these I've seen more than once, and that's the sad part. I'm going to show you some mortality on massive acute thrombosis where the whole body clots off 24 times on 24 patients, and it's big stuff. Examples of where different product selection would have averted the fatality. Why didn't I choose that arterial kidney instead of that one? Because that one broke and that one won't. And amid proper knowledge base, I know it, I knew it, I knew exactly what the problem was. I tried to tell the doctor, he didn't listen. So 3 weeks later, we go through all this stuff, and now they go and do what I said and find exactly what I said, except I didn't insist on putting my foot down, so the patient didn't make it. The first scenario is antifibrinolytic use. It's a 56-year-old female in a hospital. She was waiting for an entire year in the hospital for a heart liver. She received the heart transplant in uneventful fashion. It went smooth. Protamine was given, an Amicar drip was running. That's our routine. You run Amicar for 30 minutes after you come off bypass, after protamine's in. The liver team was going to follow. The chest was still open at that point. We were still in-house because we always stay until the patient's out of the room. The patient was placed on VV bypass for the liver transplant, and 35 minutes into the VV bypass run, the patient severely, severely decompensated. We called for anesthesia. They came in and they looked on TEE and found thrombus throughout the heart. Coagulation labs were immediately sent off. The patient was put back on bypass for the completion of the liver transplant, which isn't easy when you're fully heparinized. And we followed it by attempt to remove the thrombus that was in the heart. Post-bypass, the patient would not oxygenate. It was first placed on RVAD and immediately went to ECMO because the lungs just weren't doing anything. So prior to the second bypass run, coags were sent out, and this is before we went back on pump, and after the patient decompensated, platelets were under 20,000, severely diminished fibrinogen leukocytes, extremely elevated APT-INR. It was very clear that the patient consumed all the clotting cascade in her body, and this was her heparinase kaolin TAG, for those of you that know what TAGs look like, and this was very evidence of what happened. So I knew when we were going back on bypass, this lady's not going to make it, and this is not going to be fun. The sodium level was 143, potassium, I must have put this on animation and did not mean to. These were the labs at 11 o'clock. The incident occurred around 11:23, 11:24. The ones on the right are 11:30. Notice the strong elevation in potassium levels and the strong jump in glucose. That's an immediate indication you had massive thrombosis. Worthy of mentioning, we were on VV ECMO with no heparin running at high RPM, and the flow was relatively low because of the inflow cannula they chose. 1 gram of bolus was given at 11 o'clock, another was given at 11:10, another was given at 11:20, which I don't know why that was happening. Cryoprecipitate was given at 11:20, and many of the things I'm going to talk about in this talk involve platelets and the platelet administration, and there is some of those in cryo. As soon as they started the cryo, within 2 minutes, the event occurred. But anesthesia forgot to turn the Amicar off, so they still had Amicar running. So we're on VV bypass, Amicar running, no heparin, and we had a massive thrombosis incident. Fatal scenario number 2 involves ECMO anticoagulation amid pre-DIC. So you get these patients, they come to the OR, you got to put them on ECMO. They're basically in a state of DIC, of sepsis. So 54-year-old female came to the OR. She's hypercoagulable on her TAG. with fibrinolysis. So I've got a TEG. It's not primary fibrinolysis, and it's not secondary fibrinolysis, but she's just like ECMO patients that are on what I will call pre-HIT syndrome. They're on low-dose heparin. So you see these patients before they develop HIT, but they're still chewing up the platelets. They're giving up the AT3. They're in a pre-HIT. Well, this is like a pre-DIC scenario, and it's called the non-hemorrhagic DIC. So she wasn't bleeding, but she was very hypercoagulable. She was dosed with heparin to go on ECMO. As we came out of COVID and as we deal with sepsis patients, we are dosing these patients twice what we used to. We used to, on a routine patient, would do 50, and now we're doing 100 units per kilo. ACT of 270, heparinase Kalen TEG appeared to normalize. So we gave the heparin, and the heparinase TEG seemed to come back to normal. Transferred to the unit, anticoagulation management was discussed during the SBAR. I made the suggestion that they give another heparin bolus, or they start with an aggressive drip. Because she's septic, she's very hypercoagulable. They did not do that. They waited 6 hours and started low-dose heparin. 4 hours after that, she had a petechiae shower with diminished flows in all of her periphery. She basically thrombused. And DIC in that non-hemorrhagic state, your body's protecting itself. It's kind of like breaking that stuff down. When you give low-dose heparin, you stop that process, and now you're fully enabling the ability to clot. 3 days later, she was pronounced brain dead and support was withdrawn. DIC can result from numerous conditions, and mostly in our situation on ECMO, it involves sepsis. It's a serious disorder, and it can become hemorrhagic if it's not addressed. But usually when we see it pre-ECMO, it's in that pre-DIC stage where you're very hypercoagulable, but you're not noticing it clinically because they're not really forming the clots yet. You can see compensated subclinical stages. And then these are the 3 stages of DIC, and the third one is the worst one, and that's where you're fully hemorrhagic. So sometimes it's hard for perfusionists to understand DIC because you got DIC where you bleed to death, and you got DIC where you're hypercoagulable and you're not bleeding, and there's these stages of DIC. But almost always on ECMO, we're in that first hypercoagulable stage. You got it, just like COVID patients, as we discussed the other day, you got to hit them heavy with heparin because they're so hypercoagulable. You can put a cannula in, it's going to clot off by the time you get your second cannula in. It's a similar thing in this scenario. It was recognized early, but you don't necessarily always have the criteria to diagnose it as DIC. Treatment with heparin is recommended to slow that process down in the non-symptomatic or non-hemorrhagic DIC, the pre-DIC. Patients with hypercoagulable state must be treated aggressively, as we did with COVID patients. They did not do that. They started the drip at a very low rate. Not only did they suppress the immune ability to break down, but they didn't have enough heparin to stop the clotting, so she basically just had a massive coagulopathic storm. Scenario number 3 involves ARDS and sepsis, resuscitation with ECMO. These patients appear in a state of extreme respiratory acidosis. And you've seen it. They come to the OR, and they've been having trouble up on the floor. They usually get significant amounts of sodium bicarb, and it may lead to the condition of Central Pontene Mylenolysis. And a lot of perfusionists don't know what that term is, and every single perfusionist should be well aware of what this term is because it happens not only on ECMO patients, but it also happens on bypass patients. So I want everybody to know what Central Pontene Mylenolysis is because it's fatal. It's irreversible. Once it happens, the patient is brain dead, and you just have to say goodbye. It can occur with ECMO as well as elective scheduled bypass cases. We had a 37-year-old septic patient arrived, extremely acidotic, base deficit of -14, already received 400 milliequivalents. That's 8 amps of bicarb before she got to the OR. She was still at that point -14. Sodium level the day before was 126. After the OR, it was 156. 24 hours later, it was back down to 128. Everything's good. The problem is with Central Pontene Mylenolysis is it involves a delamination of the brainstem, and it usually occurs because of rapid changes in sodium levels. It's also known as osmotic delamination of the syndrome, presenting as a complication of treatment with patients with profound hyponatremia. So alcoholics, some patients with Parkinson's, there are patients, there's classifications out there that chronically walk around with low sodium levels. And when I say low, I'm talking 122, 123 instead of the normal 130, 134 that we usually see before we go on bypass. The most common cause of CPM is over rapidly correcting the sodium blood levels. With correction of IV fluids, the extra tonicity increases. If the correction is too rapid, there's not enough time for the brain cells to adjust the new tonicity, and it allows intracellular osmoles, as mentioned earlier. The serum sodium levels rise too rapidly. The increased extracellular tonicity will continue to drive water out of the brain cells. It can lead to cellular dysfunction and lead to eventually central pontene mylenolysis. To minimize the risk of the condition, in its most common cause, you want to not change sodium levels to the point of 0.5 milliequivalents per liter per hour. So that means you should never change your sodium levels, definitely more than 12 milliequivalents in a 24-hour window. And if you remember, this lady went from 126 to 158 back to 128, so it changed 30 within 24 hours. If they come into the OR and they're hyponatremic, and we're talking below 126 pre-bypass, you have options. You should have a protocol. I think AMSEC needs to help make perfusionists more aware of this in their guidelines, because I don't see it in their guidelines either. But CPM is directly related to low sodium levels, and you have to adjust the sodium levels in your prime. It can result in acute paralysis, dysphagia. Many conditions can result from this, but in the end, what's most important is the delamination of the brainstem that ends up being fatal in death. To prevent CPM in the hyponatremic patient, and I'm talking about the elective patients pre-bypass, but the lady that came in for ECMO experienced the same thing. She had a sodium level increased almost 30 within a short period of time frame. The rate is not to exceed 0.5 milliequivalents per liter per hour. You adjust your pump prime, and there's different things that you can do that. There's basically two options. You can delay surgery, and this is what we usually do. If we have a patient upstairs before they come, we'll leave them on the unit for 2 or 3 days before they come to surgery, and each day we slowly elevate their sodium until it's at a normal sodium level. Then we bring them down and operate on them. The other option is if it's an emergent case and you don't have time to do that, then you can adjust your pump prime. Normal sources, Plasmolite is 140 milliequivalents per liter. Lactated ringers is 130. So what you put in your pump prime matters. Mannitol it still has conflicting evidence. It does decrease the sodium level. I don't know if you've ever given mannitol bolus in your prime, but you'll always, if you put 50 grams of mannitol in your prime, you'll always see your sodium less when you first go on bypass than it was pre-bypass. It drives the sodium down, but it increases the intravascular osmotic pressure also. 3 days later, this patient was pronounced brain dead because of delamination because of CPM, and support was withdrawn. Situation number 4, direct thrombin inhibitors and ventricular stagnation. For those, we've known about this for a long time, all the way back to Ancrod, all the way back to snake venom, that you have to keep your stuff circulating if you have any form of stasis, that non-heparin anticoagulants don't necessarily work. We had a patient diagnosed positive for type 2 HIT. We apheresed them prior to elective cabbage surgery, and that's usually what we will do. We just apherese them. We go ahead and give them a one-time event of heparin, and then when they get to the unit, they don't get any more heparin. We use a different anticoagulant at that point, and that's, I know the Cleveland Clinic does that too, and it seems contradictive, but that's the easiest thing to do, and it does work. We do it routinely. 17 hours after the OR, the patient was placed emergently on fem-fem ECMO in the unit. The patient decompensated, had a low ejection fraction to start with. I was instructed to flow as much as possible due to the elevated lactate levels that had been produced and the fear of Harlequin syndrome. So we go fem-fem, and we're immediately worrying about Harlequin syndrome. They didn't want to reopen the chest and go central VA. They thought that his EF was too low. Bivalirudin was started and increased to a therapeutic level. 18 hours later, CRT was initiated because his kidneys took a hit. Thrombus was immediately witnessed within 3 to 4 hours in the ventricle, and within 24 hours grew to the size of a tennis ball. So I want to point out, and there's articles out there that demonstrate bivalirudin is not bound to AT3 like heparin is. 50% of bivalirudin can be excreted through the CRT machine. And I've seen this many times where You have a baby on ECMO and you've got bivalirudin and everything's stable, and they start CRT, and all of a sudden now the patient's hypercoagulable, and everybody says, well, the CRT makes them hypercoagulable. No, it's the bivalirudin's being pulled out through the fiber of the CRT. The patient was assessed for transplant and destination therapy. Nice guy. And this is over a period now of 3 to 4 weeks. You know, what do you do? We've got this. They were both decided that he didn't have the, not only did he not have the right social life, he had a wife and 5 kids, but it was deemed there was nobody that could take care of him in that setting. So we discussed using directional therapy with TPA or I don't know if anyone's ever used alteplase, but we've used it on ECMO several times. When we get clot, it's catheter based. You can drive the catheter right to the thrombus and break that thrombus down, but they decided that this thrombus was too large to do that. Eventually, the family was gathered and support was withdrawn. My solution in this situation would have been VAV ECMO, and VAV ECMO is now my ECMO cannulation of choice. You split the arterial line, you put 50% of the blood back to the pulmonary artery, and you put 50% of the blood to the aortic arch. That accomplishes a number of things. It reduces the afterload on the heart. When you cannulate in the aorta and you have the heart with a low ejection fraction and you're shoving all that blood in the aorta, you're creating an afterload on that ventricle, and it's making it even more difficult for the ventricle to work. Secondly, it eliminates completely the Harlequin syndrome, because now you've got 50% of your blood going through the lungs. And we routinely do this when we do double left-sided valves and they have to go on ECMO. We immediately go to VAV ECMO because it washes the valves and you don't have any risk of thrombosis. More importantly, it puts a filling volume in the heart and the heart can eject. So I've seen hearts heal so much better with VAV ECMO because there's volume in there for the heart to actually squeeze, and it's not squeezing against the high pressure that it would be if you had 100% of the blood flow going into the aorta. You can use an Impella as an LV vent in that situation, but there's not usually enough blood coming through, and the Impellas are very positional, and we've done that without success before. We've still formed clots even when, and it's just so expensive to do that, but they didn't want to open the chest and put a direct LV vent in. Number 5, massive thrombosis, and this one hurts because this is over a period, so we were going to publish this. I saw this a number of times in 20 years that I was there, to the point where I'm able to recognize it, and I want to bring it to your attention so it's on your radar, because it is very preventable. So we went through our STS database and we pulled 20 patients, which is about 0.1% of our caseload. That's almost 20,000 cases that we looked at, and we found a 0.1% rate on this. So we're a high volume institution, and it makes it easier for us to find. But I've talked to other perfusionists of programs that 150, 200 hearts. Yeah, I saw that once 10 years ago. Well, that's about the rate of 0.1%. So low volume facilities won't be able to see this and recognize it as easily, but I want it to be on your radar. The median age of the group was 66, median body weight was 80 kilo. The gender was split. No cases in which patients survived massive thrombosis event despite the initiation of ECMO. So all these patients died. Some were on ECMO, some didn't even get to ECMO, some just died on the OR table. Patients with acute massive thrombosis are high-risk surgical candidates. The mean number of cardiopulmonary, this is the mean number, was number 2. Some had 5 bypass runs, complicated cases. In 7 of the 20, the aorta was the site of the operation, either because of dissection or descending thoracic aneurysm. It wasn't, we had a couple in there that were redos, and they hit the aorta going in. But look at these numbers. The mean quantity of red cell transfusion was 6 liters. That was the mean. Cell saver was 2,300. Fresh frozen was 3,400. 85% of the patients had a transfusion rate of 1,006 of platelets. 45% with cryoprecipitate. Prolonged bypass times were seen. And it's well known that whenever you have prolonged bypass or circulatory arrest, you have a depletion in AT3, and ultimately that was the cause of all these. AT3 levels were diminished. So AT3 is a calculated response. It is 80 to 120%. So 19 to 20 of these patients that demonstrated has had 3 minutes of, it happened within 3 minutes of protamine administration. of 14 of the 20 happened with 30 seconds of platelet administration. So we're off bypass, protamine goes in, they start giving platelets, and with 30 seconds, boom. We had a 26-year-old, and the cardiac surgeon, lots of bleeding, it was aortic procedure, aortic valve that went awry on a redo. And the surgeon looked at the anesthesiologist and said, "Are you ready with the platelets and protamine?" I said, "Sir, we can't do that." He looked at me and said, "Why?" I said, "Because we're going to have thrombosis problems." And he said, "Well, the patient's bleeding, and that's exactly what we're going to do." So they did it, and the anesthesiologist on the TEE said, "We got clot in the right atrium, we got clot in the right ventricle, now the ECMO alarms are screaming. We got clot in the left atrium, left ventricle." Patient was pronounced 10 minutes later because the entire body thrombosed off. The complement side of that is the next time I went on ECMO with that same patient, they said, with that same surgeon, they said, "What do you want to do?" And he said, "We're going to do whatever Phil wants to do." So in the end, we were talking about ACTs. All of our ECMO patients get half dose of the protamine, and almost always the ACT is back to baseline. And it's because the presence of activated platelets. And in the end of these scenarios, the recipe for disaster is you've got activated platelets from this complicated run, high pump sucker, multiple pump runs. You've got activated platelets, you have protamine on board, and it's excess protamine because the patient doesn't need that protamine in this scenario, and it's the presence of AT3. So that cell saver use that you saw, that means a lot of the patient's AT3 went over into the waste bag of the cell saver. There's a fragile equilibrium in AT3 and how it acts as a prothrombic and an antithrombic in a normal patient. When we have these situations, it's not good, but normal AT3 is assumed between 80 and 120%. So I want all of you to look at the patient's blood volume and just assume that the AT3 is 100%, because in the average working adult, that's what it is. And it's between 80 and 120. So if you just assume it's 100, then you're able to look at the blood loss. And if you've lost 1.5 times or 1 time or the full, if you have a patient with 6 liters of blood volume and you've sent 4 liters to the cell saver, you're at your critical threshold. So critical low threshold for AT3 is 30%. When you get down to 30%, you can have thrombosis on major levels, even without protamine. And we did have one patient that clotted off before protamine was even given because the AT3 was so low. And it was the presence of the activated platelets. They had started giving platelets, so even though protamine wasn't in, as soon as they started dripping platelets, the native platelets are just pissed off and mad because of the angry pump runs that they had. And when the new platelets come in, it serves as a catalyst, and they just attack each other and thrombose. But AT3 level can be calculated in your head if you just think about proportion. And that's what I want to have on everybody's radar. Scenario number 6, we are converting a BIVAD back to ECMO, and this one really hurt. Sweet family. We had a 3-year-old on biventricular Berlin heart. She was a really sweet girl, fun, talking, playing. Like I say, the family was great. 3 months into the Berlin, she developed an infection, and she had diminished pulmonary function. And she was placed on a high-frequency ventilator, an oscillator. Does everybody know what an oscillator is or heard it? They're loud, just doom, 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 and it drives you nuts to watch an ECMO in those rooms, but that's what they do. I was asked if I can insert an oxygenator into the Berlin heart circuit. And I did the math, and we know that the Berlin heart is very afterload and preload sensitive. So the question is, okay, what's the pressure drop? How much can we go up that much on blood flow? Are we going to have too much of a pressure drop to push through the oxygenator, and we won't be able to fill the other ventricle? But in the end, I estimated that it was too high on the left side, but we could cut an oxygenator in on the right side of the Berlin heart. So we took a Quadrox IDA and put 9 inches of tubing on each side of it, sterilely primed it, filled it, and we were going to cut it into the right side of the Berlin heart. The patient was sedated, draped. We did a dual briefing. I briefed everybody twice just to make sure everybody was on the same page. So we went through all the steps. I was on one side. The cardiac surgeon was on the other. And we were square, and it's like, okay, let's go. So we turned off the biventricular VADs. 38 seconds. Put the oxygenator in, get both ends. He did one and I did the other. Get them in, get them hooked up, get them undone. 38 seconds, we opened both connections. The VADs were reinitiated, and the left-sided VAD just completely filled with air. And the VADs were stopped. I de-aired the left VAD. We went back on, and the situation was even worse than it was before. And I stated, I don't understand where the air is coming from. And of course, the surgeon immediately says, well, it must be the oxygenator. Well, it wasn't the oxygenator. You could visibly see the oxygenator. The faceplate on the oxygenator had no air in it. There was no air between the oxygenator and the tube going in to the heart. This hit the unit hard. In the end, it comes back to the high-frequency oscillator. That's a piston-driven mechanical oscillator and operates by high frequency. And it can go up to 900 cycles per minute. This particular child was at 190. So the frequency of impound was 190 times per second. Unlike conventional operators, the alveolar sacs don't rest. The whole purpose of the high-frequency oscillator is to increase the tension in the alveolar sac, keep it distended, keep that tension of the alveolus so that it can transfer oxygen better and lessen the dead space inside. So it doesn't get the relaxation of the diastolic phase that regular conventional ventilation provides. So when we turned off the blood flow, nobody told me I should have turned off the oscillator. So now all of a sudden the blood path pressure goes to 0. The oscillator is pushing air, and it pushed air across all the alveolar sacs into the blood path, into the pulmonary tree. And when we went back on, there's all the air. So if you're ever in this situation and you're on a VAD and you're on a oscillator, make sure you turn the oscillator off if you stop the blood flow. Had I done that, the incident never would have occurred. Utilization of a PVC cannula. I had a 4-year-old male, a 3-time congenital redo. We placed on ECMO and listed for heart transplant. 6 weeks later, the patient decompensated, the arterial pulse pressure dampened, the right-sided pressures were increasing. We suspected tamponade. We rushed to the OR. The patient was prepped, draped, the chest was open. There was significant blood loss. The surgeon witnessed blood coming out of the cannula, and when he went to pick the arterial line up, the entire thing just broke off. The entire thing separated. The surgeon stated there was no way that he could get another cannula in that 3rd-time baby's redo aorta, so we had to keep the baby alive until the family was called down to say goodbye. I was transfusing through the venous side. The hemoglobin was 3 by the time the family got there, and we turned everything off. So what does that mean? Well, we also had a 26-year-old male that was on an RVAD, and we had to cut an oxygenator in. It was RA to PA, so it's on the venous side. The PA cannula used a curved metal tip. Some people call it the Pacifico. In 11 days into the run, we had an immediate significant drop in arterial line pressure. So we're on ECMO, you got your arterial line pressure, and all of a sudden it goes from 190 to 30. And the blood flow went from 4 to 8. It just skyrocketed. And then all of a sudden, within 30 seconds, you see the arterial line tracing on the monitor diminish and go flat. We had a crisis tamponade right there, and we're pouring blood into the chest. So the chest was open emergently in the ICU with significant blood loss. The surgeon found the cannula with the metal tip missing. He pulled the cannula out, and the metal tip wasn't on it. He said that the PA was dissected, and it was irreparable. In the end, we found the metal tip inside the pulmonary artery. So what do you do in that situation? Well, I should have picked a different cannula, but I didn't know this, so this is why we're here at this meeting, so I can share with you. You should not be using PVC cannulas for arterial cannulas. Use polyurethane cannulas. So the arterial cannulas are approved for 6 hours of use, and we know that. PVC and polyurethane are both made in our market today. The plasticizers are what keeps things soft. Plasticizers, when you put into PVC, it's soft and pliable. Perfusionists are familiar with the term durometer, and we usually have tubing packs that are in the durometer of 67 to 72, and you'll hear some people say with a durometer of 72, well, that's awfully stiff, and 68 not as. Plasticizers are commonly found. I thought I had an example, yeah. And bypass tubing has it's PVC, but then so is the P-trap under your sink. The white pipes, the white plumbing pipes are the PVC also. They just don't have the plasticizers in that bypass tubing has. So the reason you put plasticizers in is to keep the PVC soft and supple. I don't know if I went on with another. I did not, so let's go back. You want that PVC to stay soft and supple. So what happens is you go on ECMO, And the plasticizers, and you've seen this, you've seen cannulas where they change color, right where it goes into the blood. The plasticizers leach out into the blood. So many years ago, we stopped using DEHP in plastics because it was leaching into the blood. We had the blood bags and it was leaching in, and we had tubing with DEHP, and everybody, oh my gosh, these babies are having neurologic issues. So we did quit using DEHP, and now we use DNHP. Stuff bleaches out and it leaches into the blood. So that makes that cannula hard and brittle. A polyurethane cannula doesn't do that. So if you're using a PVC cannula, the plasticizers will with time leach out, and they'll break, as we saw. Scenario number 7. Nope, I went backwards, sorry. This is the one where I should have really stomped and yelled and scratched and had a rooster fight in the hen yard, but I had a 4-year-old congenital male placed on biventricular Berlin heart. He was rendered inoperable. We knew that from prior operations, so we opted to do a Berlin heart and bridge to transplant. Flows would not balance, so we went on, and nothing was making sense. He just looked awful on biventricular flows. Equalizing the flow, I mean, making the flow the same in both ventricles. The lactate levels went way up. The acidosis went way up. There was poor peripheral perfusion. His nears on his flanks were really low. His fingers were blue. And flows on the left side were increased until the normal filling pressure. So everybody leaves, and I'm in there watching, and I increased I said, there's got to be something going on here. So I increased the left side and kept increasing the left side until everything suddenly balanced. Everything looked good. So before, the right ventricle in the Berlin wasn't able to fill properly. So I went up on the LVAD to push more blood to the RVAD side, and now both ventricles are balanced. They're both filling. You can see the membrane in there. You can see on the diastolic phase, it's collapsing. It's looking normal. The only problem is, once I reached that condition, my left-sided flow rate was 126. It was 26% higher than on the right. So my flows were 26% higher. So we had some kind of recirculation thing happening. And I told him, we got to go to cath lab, and we got to figure this out. Something's not right. There's an anatomical issue, because when you go up, everything looks great. All the saturations, all the nears, everything normalized. Well, we didn't do that. So 3 weeks of misery, and we ended up putting this patient on VA ECMO, and we couldn't make anything work. They took the Berlins out and went on VA ECMO, and that didn't work. And then we went back on Berlin, and then we went on VA ECMO again. And finally, it's to the point where, death is knocking on the door. And I had the discussion with the cardiologist of what we saw on that very first day. He said, well, let's go. So we went to the cath lab, and lo and behold, they found a 24% recirculation. And had we known that on day 1, we could have gone to IR, and they could have cauterized and stopped all those collateral flows, and life would have been good. But that's one time I wished I'd have done it. So if you can't get something to balance, if you can get something to balance and it's abnormal, try to figure out why. And I wish we'd have gone. So in these fatalities, antifibrinonuclear use emit insufficient heparin level. You don't want Amicar running if you don't have heparin on board. You got to have a sufficient heparin level. Mismanagement of ECMO with pre-DIC state. You have a low therapeutic level. Acute ARDS. Be aware of giving too much sodium bicarb. Also to patients that are coming for pre-bypass with low sodiums against Central Pontene Mylenolysis. And I really encourage all of you to go look that up and say, what is this? Because it's very real in our world. I've seen at least 12 patients in probably the last 10 years die of this. And in every situation, I think it was preventable. DTIs and ventricular stagnation. There again, VAV ECMO is the selection and tool of choice in my arsenal. Acute massive thrombosis, you got to have AT3 on board, and it's a mathematical calculation, and I put this square directly on perfusionist's shoulders because there's nobody in that OR that knows more about the volume status of that patient than you do. So if you're down 50%, if half your volume has gone to cell saver, in addition to your prime going to the patient, know that your AT3 is 50, but if 2/3 or 3/4 or an equal 100% has been lost onto the floor into the cell saver in a resuscitation effort, be asking for some AT3. Conversion to BiBAD, don't stop the blood flow in a PA's pulmonary blood flow tract when the oscillator's running. And you won't read that in any textbooks anywhere. That's crazy too. Utilizing a PVC arterial cannula is bad. Try to go with a polyurethane. The new Biomedicus cannulas are polyurethane. There's still a lot of PVC cannulas out there. So if you know you're going into a long-term ECMO, I don't even like using the cannula. I'm encouraging the surgeons just to sew a graft on the aorta. Put a graft on that aorta, stick your cannula in that graft. If there's a problem down the road, it's easy to change. It's not easy to change a cannula in an aorta. We had a patient on ECMO for a full year, and he ended up after 1 year of having a degradation of the arterial cannula site in his aorta, and he was bleeding, and we couldn't stop it. And I had to beg him and plead him to let us turn him off. And it wasn't, I mean, that 1 year, we really got to know him. And those kind of things hurt. If you have unbalanced blood flow in a BIVAD, try to figure out why. And that's it. Thank you.